Okay, so respiratory system, its overall main function is breathing. Okay. Um, the fancy word for breathing is going to be ventilation. And we have two parts to ventilation. We have inhale and exhale. Okay, so inhale is where we breathe in, and exhale is where we breathe out. Okay, other functions that the respiratory system helps us with is gas exchange, does help us with sound. So we speak and all the different noises we can make, singing, all that, does come from the lungs as the air comes up and through the vocal cords. So sound production. It does help with olfaction, which is cranial nerve 1, okay, which is smell. And it does help with some defense. So one of those would be acid-base balances. Okay. Um, so you don't want your body to be too alkaline. You don't want your body to be too basic. And if you go to either extreme, acidic or basic. Okay. So let me say that again. You have the acidity side, which would be closer to 0. Okay. Or you can go to the alkaline or basic. Okay, so that one has two names, alkaline or basic, which would be closer to 14. So if you're working your way to acidic, that's dangerous. And if you're working your way to alkaline or basic, that's dangerous. And so your respiratory is one of several systems to help you stay within balance. Okay, we do also find different Pac-Mans inside of our respiratory system. Uh, they are macrophages and other white blood cells uh, called dust cells. Okay, so once those white blood cells enter into your lung area to help defend you, they call them dust cells. Okay, you also have the mucus. Okay, so for defense, you have the mucosal lining. So the mucus lines a lot of tubes in our body, right? So respiratory passageway is one of them, and also the cilia. Okay, so the cilia will move particles away from the lung field. Okay, do you know the difference between the upper respiratory tract and the lower respiratory tract? Okay, for one reason, you'll likely hear, especially in a clinical setting, things like, patient in room A has a lower respiratory tract infection, or, this other patient we're dealing with an upper respiratory tract infection. So you'll usually hear it from that perspective. So when you hear those terms, upper or lower respiratory tract, it's a good idea to be able to visualize and know what we're dealing with. So um, one easy way of looking at it is about the throat area. Okay, you divide a line, an imaginary line, around the throat area. Okay, and more specifically, the Adam's apple area, which would be the thyroid cartilage. Okay, so about the level of the thyroid cartilage and up is going to be your upper respiratory tract, and then about the thyroid cartilage and down is going to be your lower respiratory tract. So it's just a really quick and easy reference to visualize upper versus lower. Okay, and do know the parts to the upper and lower. And this will also be a lab, a future lab, part of lab tests. Okay, so as you're taking notes and marking things, just also put in there, know these for lab. Okay. So with, just to give you a heads up with testing stuff, with the lecture part of the test, all that's written, through questions and multiple choice and things like that. Not really a lot of pictures on the lecture part, okay? But in lab, that's pretty much all it is pictures, all right? So arrows pointing to different areas, what's this, what's this, what's this, and that kind of thing, okay? So from that perspective, just mark all these areas so that you know the gross anatomy. Okay, so starting from the top with us upper, okay, this particular slide does break it down nicely, okay, where the upper respiratory tract parts are. So we have this sphenoid sinus, okay, because it's located in the sphenoid bone, or the sphenoidal sinus. Okay, we also have the frontal sinus. Okay, the frontal sinus located in the frontal bone. Now these are cavities, as you can see there. Okay, so it's a cavity in the bony space, and it is lined with a membrane. And if these get inflamed, you get the so-called sinus infection. Okay, we have the nasal cavity. Okay, so this area has concha. Okay, so we find concha in there. And then you have the pharynx. Okay, so the pharynx is essentially the back of the throat area. Okay, then for lower, all right, there's the larynx, the trachea, which is your windpipe. Okay, and then you have the bronchi. So as the trachea is coming down, it does split into the primary bronchi. And then those split into the secondary bronchi and tertiary bronchi to the terminal ends. Okay, we'll talk about that later. Okay, then the lungs itself, you have the right and left lung. So the right side, left side. So we do have two lungs, the right and the left lung. You have the pleura and the diaphragm. Okay, so see, these are some of the major components of the respiratory system. Now we'll look at some more specific components in a little bit.
Dr. J?
Yes.
Would that also include the other two groups of sinuses, or is that considered the nasal cavity?
Whoops, let me go back. Yeah, we do have maxillary that's in there, and ethmoid. Is that what you mean? The ethmoid
Yes.
sinus and the maxillary? Yeah. So those are also included. It's just not in this particular picture.
Okay.
Okay, so a couple or some more specific parts. We have the pharynx, which has 3 different components within the pharynx. Okay, the upper part is the nasopharynx, and the middle part would be the oropharynx, and then the lower part, laryngopharynx. Okay, with your Q-tip tests, so right now the popular one is the COVID NAA test. Okay, so what you're doing is you're taking basically a sterile fancy Q-tip and going way back into the nasal cavity there. Now I do this test in my office, and what people think is that you're doing this. Okay, you're going up and stabbing their brain. That's I have to say that's the number one. Well, pretty much the number one question. The top questions are: does it hurt? And are you going to stab my brain? Like, why do you have to go so deep to stab my brain?
I'm like, no, it just tickles your brain. It's okay.
Yeah, right. So, but I guess from their perspective, no one really, I guess, let's just say lay people don't really know this, that you go straight back. Okay, it does seem like you would go, I guess looking at it from their perspective, it does look like you go up and would risk hitting their brain. So, so I have this really simple anatomy chart that pretty much has this picture, and I just show them, I was like, no, we're not doing that. We're going straight back. Okay. And there is actually a comfortable way of doing this. You don't have to, and it's just, that's using gentle hands. Okay. So I get it. Some of these drive-through places, and, they're busy and there's a line of cars or whatever, and they're just trying to go fast. Technique and all that can change. So I get it that, if you're doing it quickly and it's not really the best environment, it can be uncomfortable. But in a controlled environment, they're laying there, you can go nice and easy, get back there. It's actually not that bad. Okay. There's another technique I do, and this is a little rabbit trail. It's called nasal specific. So with my patients that have chronic reoccurring sinus infection, difficulty breathing, a more narrow nasal passageway, especially the concha back in there. It's called nasal specifics. What we do is we take a stent and we go in, okay, and then you take the stent and inflate it. So it goes from, this flat stent, and then when you blow it up, it enlarges, right? And then what that does is it opens up the concha area. It can move the ethmoid bone, and a little bit of this sphenoid, maybe even a little bit of vomer bone that's back there. Certainly the soft tissue that makes up the concha, and it takes let's just say, looking at it from the front, takes a small hole and makes it a little bit bigger. Okay. And so it does help significantly increase their breathing ability, and also helps promote drainage. And so because of that, they get less sinus infection. So it's kind of neat. But anyway, point is for many, many years and, countless times, taking a stent and going in, very carefully, taking a Q-tip and getting all the way back to that nasopharynx area is really not a big deal, and it can be done very gently. But the idea is to get that sterile Q-tip, to get cells on that Q-tip. Okay, and so the idea is, if you have the presence of a virus, in this case, because it's the latest thing, the COVID, you're looking for what they call the NAA test, which is the nucleic acid amplification test. Okay. Okay, nucleic acid amplification test. And the idea is the virus, I'm going to keep this really simple. There's the virus, okay? It has its own DNA, right? So when you take the Q-tip and you go to the back of that nasopharynx area and you kind of twist it, do a bunch of 360s, contacting that nasopharynx area, getting, making contact with the tissue, getting as many cells as you can on that Q-tip, okay? Then you put it in a special solution and then send it to the lab so they can do their testing. And what they're looking for is just the presence of the virus, right? Because the virus has its own DNA. So obviously, if they don't see anything, then that means you don't have presence of the nucleic acids from the COVID and likely are negative. The other test that I do is IgG and IgM. So this one's blood. Okay. So draw the blood. It's a 2-for-1. So you're going to get both of these. IgM lets you know you have it now. IgG lets you know you've been exposed to it. Okay. And likely it takes about 14 days for the IgG to show up. Okay. So anyway, since we're looking at the lateral view here, the nasopharynx area, just thought I'd share that's the idea behind the Q-tip.
So, Dr. J, do they have to look at that under a microscope for every single test, or do they have something that reacts to the DNA?
Yeah, let me think. Good question. What does the actual lab do as far as the chemistry? I don't know. Once it gets to the lab, those technicians.
I don't know either. Well, maybe I'll ask next time I'm at work.
Oh, they doing it at your work?
Oh, yeah.
Okay. Let me see. What would they do? Just trying to think almost common sense here. So when a technician gets the cells, I know it's an amplification test. So hold on. That means it's a culture. Yeah, I'm not. Would it be a petri dish? I don't know. I'd have to look it up.
Just with the thousands that we're doing every day, I can't imagine that someone would have to look under a microscope for every single one, but who knows?
Yeah, well, I know they amplify it, so it's an assay. I mean, that's the reason for the amplification. Yeah, I don't know. Let me look into that later. Because on my end, I'd have to admit, on my end, another thing we do is other blood tests, right? We can look for your cholesterol scores, thyroid, and so on. I mean, really anything, you can order thousands of labs. I've never really bothered to look at it from the technician's part. Like, what do they do in their actual chemistry lab? They don't really teach you that part. They just teach you all the other stuff.
I get curious too. And sometimes I'm like, maybe I should just see if I could shadow someone in the lab for a day just to answer those questions. Cause I think about it every once in a while, but yeah, you don't ever really learn it.
Yeah, I've seen labs. I remember doing a walkthrough years ago. I mean, it really is just one big fancy chemistry lab. if you didn't, if I blindfolded you, took you in, took off the blindfolds and say, what do you see? You'd be like, looks like a chemistry lab, you know, and then it would take you another minute to figure out, oh, it's chemistry for, you know, blood and all that other stuff that they send in for. All right, I'm going to make a note to look to see, because now you got me, my curiosity up. All right. Okay, so here's the concha. So in the nasal cavity, and by the way, this whole area is designed to increase the surface area so that when you breathe air in, okay, as you're breathing in through the nose, the air has time to circulate and actually be warmed before it goes into the lung field. So there's a lot of blood vessels in there, a lot of superficial blood vessels to allow for that air to be warmed before it gets into the lung field. The other reason why nosebleeds are relatively easy to get is you have a very thin membrane and very thin capillaries. And so it doesn't take much to pop them, so to speak, and have them leak through tissue. And there's your so-called nosebleed. And the other thing is your risk for infection goes up once you get into the nasal cavity. So like dirty fingers, for example, very, very easy to take your hands and your fingers and touch your face, including your eyes, your nose, and your mouth, okay? Very, very easy to do. And so you just have to be mindful that if you do that, that your hands are clean, and, you know, just limit the amount of contact you do. This becomes especially important in, you know, more hospital situations because, you know, they deal with doing CPR on people. They deal with more emergencies and different codes where people are dying and you're trying to save them. A lot of body fluid, a lot of vomiting, nasal discharge. I mean, you name it, hospitals see it all, right? In a world like mine, I see that stuff very little. Um, you know, I don't really see a lot of blood and vomiting and bodily discharges and things like that. It does happen. It's rare. So I don't overall have to worry about it. But those of you in hospital situations, you do. Okay. Because pathogens or opportunistic organisms can get through that membrane very easily. Also, once it gets into the mouth, uh, you know, chances for infection go up. So that's why I use a barrier, uh, you know, the bag valve masks and so on. Okay, different ways to protect yourself. Okay, so the nasal cavity has the superior nasal concha located on the topmost, the middle nasal concha, and the inferior nasal concha. Okay, and so in between the concha, which by the way are formed by bone. So back in your ANP1, you know, when you're looking at a skull, looking inside, you can kind of see those bony protrusions that make up those concha. Okay, then the spaces are called the meatus. So you have the superior meatus, then the middle meatus, and then the inferior meatus. And so when I do that nasal specific, I'm mostly hitting the inferior meatus, and then you inflate that area, and then you come back, you come out, then do it again and go after the middle meatus. Okay, the superior meatus is usually okay. That one's usually not closed off, so to speak, in people. This one, the middle and the inferior are. Okay, so I take a speculum and your scope, so it's the ophthalmic scope, but the nasal speculum, and, you know, I go up and you can take a look. I also have a camera, so a special lens hooked up to a computer that you can go in as well, so that you can take pictures and the patient can see it. that kind of thing. So you're just basically kind of doing a nasal exam. And most of the time, actually, let me say that better. 100% of the time, it's very easy. So here it is. Person comes in, and let's say it's the left nostril. Okay. So you ask questions like, so which side do you have a hard time breathing out of? And they'll say, it's always my left side. Every time I get an infection, it seems to be the left side. Every time I have issues, it's left side. So in this example, everything's on the left. Okay. So when you go up and look with the camera, the speculum, and you compare it to the right side, it's very, very easy, very obvious to tell. The left side looks like this, just very small holes, and the right side looks like that. Okay. And so then we'll go into the left side and start to inflate everything. Also, in that example, if you take this stent and go into the left side and then go into the right side, the resistance is remarkably different. Okay. Trying to take a stent, put it in a tiny hole like that, the resistance is high. Take a stent, put it in a nice big open hole, it slips in very easy. All right. So it's each inflation lasts about 5 seconds. Okay, and you can do that about 3 to 6 times, depending on what they can tolerate, and usually about I think the most I've ever done as far as treatments on someone is 8 visits. Okay, that's kind of high end. Most people after one they're fine, maybe 2 or 3 visits and they're fine. Okay, I get it done. Uh, I probably just do a maintenance thing of once a year now. Back in the day, I got a bunch done just to help, and then now it's fine. Like I do great, but I can tell after about a year, I think I need to tune up, and then I just go back in and get things kind of open back up. It's wonderful. Okay. Um. All right. So then, uh, other anatomy parts. Okay, you have the uvula. Okay, which is when you look in the back of the throat, it's that little, I call it a speed bag, right? It looks like one of those boxing speed bags. So when you look in the back of the throat, that's the uvula area. Um, Now we're getting into the pharynx, okay, that we saw before. There's your nasopharynx, the oropharynx, and the laryngopharynx. All right. Oops, let me make this less busy. Okay, then we have in the larynx area, you are going to find the epiglottis. Okay, that is the flap that covers the trachea. Okay, that's your windpipe. The trachea is your windpipe. And the idea is when you swallow food or drink, you want the food to be routed into the esophagus. Okay, so in this lateral view, the esophagus actually lies posterior to the trachea. It's behind the trachea. All right, so if you look at a person from the front, an anterior view, the first tube you come to is the trachea. So you can do a tracheotomy a lot. I mean, you can, because it's right there in the front, and then behind the trachea is your food tube, the esophagus. So you want that epiglottis to cover the trachea so that food is not routed down your windpipe. Okay, so you want that epiglottis to cover the windpipe. Now, one of the reasons why people choke is because, now remember, sound is produced by wind or air coming up from the trachea through the vocal cords and out you go, right? So that epiglottis has to be open in order for sound to be produced. So typically, you're choking victims uh, when eating. I mean, listen, when we eat, it's very, very common to eat and socialize and talk at the same time. It's very common. So it's easy to do, right? As sound is trying to come up, the epiglottis is open while you have food in your mouth trying to swallow, so it can get stuck, okay? So you just have to be really careful when doing that, you know, making sure that you coordinate your talking and chewing and swallowing at different times. Um, and then with young kids, you know, toddlers, that kind of thing, uh, boy, nature and man has created these amazing things. So grapes were like, they're the perfect size to block a trachea. So that's nature made. And then the other one is hot dogs. Okay. So what usually the parent will do is cut the hot dogs up into these nice, perfectly circular, um, covers the trachea beautifully, uh, you know, when sizes, right? So you just things like that. You just have to be careful when you're dealing with someone really little. The food is cut up small enough to avoid um, getting stuck like that in the trachea. Okay. Um, let's see. Okay, so here's some of that same stuff in a cadaver. Oh, a couple more things. I do want you to know the tongue. Okay, pretty easy there. Okay, from the front are different sinuses. Okay, so there's the frontal sinus. Okay, the ethmoid sinus, phrenoid sinus, which sits really deep. I mean, that gets way back there. And then the maxillary sinus. Okay, so the order, here, give me a second here. All right, I'm going to use, instead of using this picture, okay, I'm going to use this picture just because it's a prettier picture. Okay. So to continue with lower respiratory parts, um, the trachea, okay, comes down and it splits into the right and left, what they'll call the main bronchus or primary. Bronchus or bronchi, depending on the book and whatever the author. Okay. So I tend to use the primary language. So the first branch, even though they're both AKAs, the left main bronchus, the right main bronchus, okay, or the left primary bronchi or the right primary bronchi. So that is the first branch off of the trachea, the primary bronchi. Okay, then it branches again into the secondary bronchi. All right, and then branches again into tertiary. That should be an E. Okay, tertiary bronchi, and then the terminal ends. Okay, and that's where you find the alveoli. Okay, so this one shows it with the trachea and then that primary bronchi. Okay, the secondary bronchi is also known as lobar or lobar. Okay, tertiary is segmental, which is the yellow that you see there, all the way to the terminal ends in the red there that they call are also known as the smaller bronchi. Okay. So I tend to use that language, even though they're both AKAs of each other. All right. You'll also notice that the right lung has 3 lobes. 1, 2, 3. Okay, so it has 3 lobes. And the left lung has 2 lobes. All right. Another thing clinically, since we're here, is if a person is going to get something stuck in the lungs, okay, so aspirate or whatever, it will likely go into the right lung because the primary bronchi sits more vertical and the left sits more horizontal. Okay, so as far as something traveling down a tube, they tend to take the path of least resistance, so chances are it will go into the right lung. Now listen, that's not every time. Obviously things can get stuck into the left lung as well. Just statistically speaking, chances are it will go into the right lung. But the left lung is not exempt. Okay, at the very end, so once we get out to the more distal areas of the lung, okay, this is where you're going to find the alveoli. All right, the alveoli is the area of gas exchange. Okay, so as you're coming in, and now keep in mind in this picture, we're more distal now. Okay, so we are way out here in the distal part of the lung field. You're getting into your terminal bronchioles. Okay, because they're coming to an end. Terminal bronchioles. Okay, then you're going to get into the respiratory bronchioles that then give rise to the alveoli. Okay, easy way of looking at this is like a cluster of grapes. So if you ever hold a cluster of grapes, the grapes are attached to the stem part, and you can pull a grape off, right? So you can pull that one grape off of its respiratory bronchiole. Okay, and there's obviously lots and lots of grapes, so we have millions of these alveoli. All right, if you split an alveoli in half, or you cut the grape in half, you're going to expose the alveolar duct and the alveolar sacs. Okay, from this one, from this particular view of the larynx, you can see the epiglottis. It's the area that covers the windpipe. Okay, hyoid bone. Probably remember that from ANP1. Okay, here's the thyroid cartilage. In layman's terms, people tend to call that the Adam's apple. And I have literally gotten this. People that just don't know, they think men are the only one that has thyroid cartilage or Adam's apple because they tend to be more prominent. They stand out more, and women not so much. And so, well, don't only men have that? I'm like, no, both do. Just tends to stand out more in men. Okay, below the thyroid cartilage is the cricoid cartilage. Okay, so if you are going to learn to do a tracheotomy, they'll teach you to palpate for the thyroid cartilage and then the cricoid cartilage, and you can actually feel that on yourself. Okay, now it's be hard to for me to show you and explain it to you over Zoom, but if you palpate your own Adam's apple or thyroid cartilage and you work your way inferior, there's a distinct hard cartilage, which is right here, okay, the inferior aspect of the thyroid cartilage. Then you'll feel a soft spot, okay? And then you'll feel another hard part called the cricoid cartilage. All right, so they'll teach you to palpate for that because those will be landmarks to do a tracheotomy. Those of you who are going to, have to be responsible for any of that one day.
My plan's to do it on an airplane with a pen.
Yes. Oh gosh, what comes to mind is that movie. Boy, it's an old film now. Anaconda, I think it was called, with John Voight.
Oh man, yeah.
That's old school. But that happened. A guy, I haven't seen in a while, but what happened was a guy got stung. Like they're in the Amazon or something. So all animals in the Amazon are like 5 million times more potent than animals in the United States. So like a bee sting in the US, it's like ow, and it's local, but a bee sting from the Amazon, like, you go into instant anaphylaxis and everyone dies. So that's what happened. He got stung by some Amazon bee, and his throat started to swell up. So John Voight's character took a pen of some sort and did a tracheotomy to help him breathe.
Totally forgot about that. Yeah.
And then after that, they found that wasp or whatever flew out of the mouth. And like, oh, that's what caused it. If we were to look at the animation on that today, we'd be like, what? That is so old school. But at the time, man, it was cutting edge with the graphics and all that. All right. Okay, the vocal cords. So once you go into the mouth, let's say you've got a scope, you're going into the mouth, going down behind the, back on the posterior side of the tongue. Now you're getting into that trachea area. You would find these, okay? You would simply find the vocal folds, okay, or the vocal cords. Okay, so that area is called the glottis. Okay, so the glottis is where you find the vocal folds, which is also the vocal cords. And as air is coming through it, right, they vibrate. So there's a vibration there that gives us our sound, okay? If it gets inflamed, okay, then obviously you sound funny. People will refer to the larynx as the voice box area. Okay, here's another view of that thyroid cartilage and that cricoid cartilage. Okay, trachea comes down, splits into the primary, then eventually into the secondary, and then tertiary, and then terminal ends. All right. Okay, the trachea is composed of these hyaline cartilaginous rings. Okay, so we have C-shaped hyaline cartilaginous rings. Okay, you also might read them as the tracheal cartilage, but they are made of hyaline cartilage. Okay, what happens is, let's see, let's go back to this one. So if you were to squeeze this tube, okay, if you were to squeeze the trachea and then let go, it will go back to where it came from because of the hyaline cartilage. So it's not very collapsible, all right? It stays nice and open. Okay, from a superior view, okay, we have a cross section. You can see the nice opening of the trachea there, and then a little bit of the opening of the esophagus, so your food tube. Okay, this is largely smooth muscle. So as things are found inside of the esophagus, the smooth muscle will contract, and that peristaltic wave will move that food from point A to point B, right, as it's moving down. Okay. The trachea on the inside does have, it is made of the pseudostratified columnar epithelium. Me personally, I like to use its full name, which is ciliated. Okay, ciliated pseudostratified columnar epithelium, because you do find cilia that lines the inside part of the trachea. You also have goblet cells that secrete mucus. Okay, very important function. It's a big part of your defense system in the trachea. Smoking typically starts to hurt this over time. Okay, right here you can see the mucus layer. Okay, and it's always working for you, right? So if you're not symptomatic, you really don't notice much of the mucus stuff. You will notice it if you become symptomatic, like for example, fighting a cold because of the excessive production of mucus. And that's just your goblet cells and your immune system working in overtime, trying to get rid of the bad guys quicker. Okay. So just all that work they're doing, that's why you get the excessive production of it. Okay, another picture of what we talked about. Trachea, primary, secondary, tertiary, and then the terminal ends. Okay, all the way down from the bronchioles to the terminal bronchi, and then the alveoli. Okay, as you work your way down the trachea, okay, so all the bronchi are going to be lined with that, or these particular ones are going to be lined with the pseudostratified columnar epithelium. Okay, now the farther you get to the end, okay, toward the terminal ends, it changes its tissue into simple squamous epithelium, okay, which is, remember, simple means one cell layer thin, and you want it to be super thin because gas exchange is very nice through very thin tissue. Gases and diffusion and absorption do not like to go through very thick walls. Okay, so that's why when you look in the body, back to your histology stuff, everything that has to do with diffusion, absorption, and secretion, they're all thin. Simple squamous, simple columnar, simple cuboidal. Okay, all those have a function of either diffusion, secretion, or absorption. Okay, so gases like to uh, go nicely through simple squamous epithelium. Okay, the other thing, just to piggyback on the histology thing, tissues that are very thick, so you're stratified, those are usually for protection, abrasion resistance, okay, things like that. Okay, so we do find smooth muscle in the bronchial area. Okay, and that's important because it is, first of all, it is innervated by the autonomic nervous system. And some quick and easy things, when you start to exercise and your heart rate goes up and breathing and all that goes up, you want the bronchioles to dilate. Okay, so they have the ability to bronchiodilate or open up. Okay, now the sympathetic nervous system, so the SNS, sympathetic nervous system, is the one responsible for bronchial dilation. Okay, bronchial constriction is going to be more of a parasympathetic response. Okay, so when you're in rest and digest mode, there's no reason for things to be all dilated and lots of blood. So things are more relaxed and chill, so you have more bronchoconstriction. Okay, now if your body throws a fit, such as asthma or other allergy responses, then we're dealing with a different ballgame here. Okay, so that's where things spin out of control. The default is usually constriction. Okay, some sort of bronchial constriction, closing off airway stuff. So what'll happen is you'll take something like albuterol or any kind of what's called sympathomimetic drug. Okay, think about that word, sympathomimetic. It mimics the sympathetic nervous system, and the job of the sympathetics is to bronchodilate. Okay, so the presence of that medication will open up the airway. Okay, so once you get to the end of the respiratory bronchioles, now you're getting in here to seeing the alveoli and then what's inside. Okay, and then this one's pretty nice, and we'll go back to the other one. You've got these blood vessels, okay, so pulmonary capillaries. Well, it's right here. The pulmonary capillaries that surround themselves around each one of the alveoli. Okay, So there's an alveolar sac, another alveolar sac. So all these are grapes, right? And then inside you open them up and you've got the alveolar ducts. Okay, so what happens is oxygen is put in and then delivered to the vessel, like your capillaries, your pulmonary capillaries, and CO2 is given up. Okay, and then eventually you breathe that out, right? So there's this constant exchange of gases. This is what they look like under a microscope. Okay, the alveolar ducts. All right, hold on a second. Okay, so let's pause. Let's take a, what time is it? Let's take a 15-minute break. Okay, we'll come back at about 5 after 10 or so. Okay, so see you in a bit. Okay, alveolar type 1 cells are made of these simple squamous epithelium. Okay, the thinner, the more rapid the diffusion. The type 2 cells, okay, have almost a cuboidal shape to them. Okay, so squamous would be, that fish scale-like, cuboidal, and then columnar. Okay, one cell layer thin. That's where the simple comes in, one cell layer. Okay, the alveolar type 2 produce the surfactant. Okay, surfactant helps reduce surface tension. Okay, it also offers a little bit of lubrication. Okay, a little bit of moisture that's inside of that area, a surfactant. Okay, you also find macrophages inside the lung field, specifically the alveolar here. And they are called, once they get into the alveoli, they're called dust cells. Okay, and these macrophages are working all the time. Okay, we're constantly breathing in air particles and just, things and substances and whatever that just airborne things. Okay, you're always breathing in stuff that your body is constantly having to filter out and or get rid of via your immune system. Okay, here's that gas exchange we drew out earlier. Okay, the very thin membrane where carbon dioxide and oxygen can diffuse. Okay, another nice picture of that, the diffusion of CO2 and oxygen. Okay, there's a dust cell right there, an alveolar macrophage. Okay, the pleura, okay, we've got the layer of the pleura that actually touches the lungs is called the visceral pleura. Okay, and as we're working our way out, so we're going to go from the lungs and work our way more distal. All right, so the next layer you would come to would be the cavity, okay, the pleural cavity, which is a space. And then the outside layer would be the parietal pleura. Okay, so visceral, pleural cavity, and then parietal pleura. Okay, this just explains the picture we just looked at. Okay, also, let's see, clinically, if the lungs, and I've actually got some videos on this you'll see later. If this area gets punctured, okay, so the pleura, that would be a pneumothorax, okay? So in my world of dry needling, this is something that we have to worry about, okay, be on high alert. Now, it's if you know what you're doing, it's just not going to happen, right? Because of safety, okay? It's just like giving an injection. Like if you know what you're doing, you're not going to hit something very sensitive like the sciatic nerve or, you know, the femoral artery or whatever, okay? If you don't know what you're doing or you're not careful or you're not following your clinical guidelines, that's when you start to hurt patients, okay? So, you know, it's just one of the therapies I do. Dry needling is amazing. It's such a wonderful technique to get people better, especially with musculoskeletal issues. But if you're doing it over the thoracic cage, you do have to be concerned about going too deep and puncturing through the pleural cavity, okay, or the parietal pleura, all that stuff. Now, in this particular case, the needle is so skinny, okay, they're roughly about a 40 gauge, so they're super skinny. The hole that you would create, it sucks. They're going to feel it. It's going to hurt, okay? Usual symptoms with pneumothorax stuff. But it's typically on the more mild end of things because the puncture hole is so small. And it's also one of those things, as they say, it's wait and watch, okay? Because the body can reseal itself and things can go back to normal within a couple, 3 days. However, if that doesn't happen, then they'll likely have to intervene medically, okay? Now that's in my world. In other cases, you can get it from fractured ribs. Okay, the trauma can be bad where you break ribs and it pierces through the pleura, stabbing victims. And I don't mean with a sterile 40 gauge needle in a controlled environment. I'm talking like, you know, violence stuff. So stab victims, you know, gunshot wounds, and they can be spontaneous for no reason. They just can happen. Okay, so spontaneous pneumothorax. But anyway, it's a piercing of this where you basically get a hole, and it causes air to enter, and the lung starts to collapse. Okay, because of change in pressure. All right, the right lung has 3 lobes. Okay, the superior lobe, the middle lobe, and the inferior lobe. And then the left lung has 2 lobes, just the superior and inferior. Okay, pretty simple, meaning it's just named after location, the top one, the middle one, and the bottom one. Okay, and then on the left, it's just the top and bottom, but you use the fancy terms, superior, middle, and inferior. All right, we have the fissures that separate them. So you have the horizontal fissure on the right lung, and then the oblique fissure. So the horizontal, it runs more horizontally. The oblique fissure runs more obliquely or diagonal. Okay, and then the left lung just has the oblique fissure. All right, the heart does displace the left lung a little bit, and also gives it this what's called a cardiac notch, little indentation there. Heart does favor more of the left side. So behind that sternum, the heart does favor a little bit more to the left. So it would push in a little bit different on the left lung, giving it that cardiac notch. Okay, the apex is the top part of the lung. The base is the bottom part. Okay, keep in mind in anatomy, it doesn't mean top or bottom. Apex is any organ or tissue or whatever that comes to a point, and base is anything that is relatively flat. Okay, not top and bottom, just things that come more to a point, and things that are relatively flat is apex and base. Okay, the medial view of the lung, this is the hilus of the lung, hilus or hilum. If you take a sapling tree, right, that's got all the roots, and if you pull that sapling out by the roots, okay, you're now looking at the root system. That's what this kind of looks like. So that's where it gets the word hilum. Okay, it's a root pluck. So all these wires and tubes and stuff coming in and out, just like you would expect on a tree sapling from the root system. Okay, don't worry about this particular slide. Okay, pulmonary circulation. Okay, pulmonary circulation is blood to and from the gas exchange from the lungs. Okay, pulmonary circulation, gas exchange within the lungs. Okay, the bronchial circulation, okay, delivers blood directly to and from the bronchioles. Okay, delivers blood to and from directly from the bronchioles. And this part will help oxygenate the lung tissue. Okay, don't worry about lung lymphatic drainage. Okay, pulmonary ventilation. So these are the different kind of breathings that we have. Pulmonary ventilation in lay terms is breathing. Movement of air in and out of the respiratory system. Okay, so the movement of gases will follow Boyle's law. Okay, so during the inhale part, the volume of the thoracic cavity increases. Okay, so if you think about it, if you breathe in, now in this case, we're going to exaggerate it. You breathe in very deep, just a deep breath in. Okay, your thoracic cage increases in size, it expands. Okay, and this expansion allows air to flow into the lungs. Okay, and then during exhale, as you breathe out, then the thoracic cage starts to decrease in size. Okay, now this has to do with volume, right? So I'm going to use a balloon analogy. So here's a balloon at rest. Okay, and you're going to blow into the balloon, or in this case, inhale. Okay, with referencing the balloon skin itself, we're going to inhale, okay, which means you're going to force air into the balloon, and it will simply increase in size. Okay, because you're increasing. Now look at the volume. The volume is remarkably different than the balloon at rest. So you're increasing the volume. All right, then when you exhale, okay, we're decreasing the volume. So the volume will change. Okay, now Boards isn't going to say it that way. All right, with Boyle's law. They're likely going to say, something in the family of, it's the law stating that the pressure of a given mass of an ideal gas is inversely proportionate to its volume. Okay, inversely proportionate to its volume. They're going to use fancier words. But what that means is what we said earlier, okay? You breathe in, you create more volume, therefore more air can come in, and when you exhale, you produce less volume, so you push air out. All right, the muscles that we use for breathing, okay, you're going to have okay, let me say it this way first. You basically have two types of muscles for breathing, okay? Now, we'll keep it simple at first, and here it is. You have your normal, okay, your normal breathing muscles, okay, normal breathing muscles. And this is regulated by the autonomic nervous system. Now, this one's weird, okay, so bear with me on this. This one's weird because skeletal muscle is voluntary. You can choose to move your skeletal muscle or choose not to move. But we do have some exceptions. Okay, one exception are your breathing muscles. Okay. Now, the primary breathing muscles, okay, the primary breathing muscles are going to be the diaphragm, and the intercostals. Okay, the diaphragm and the intercostals. Okay, now what I mean by normal breathing, okay, is, now we're going to get a little fancy here. Your brain stem between the pons and the medulla, and the nerves. Okay, we'll talk about those in a minute. The nerves, that is. All right, these will regulate breathing cycles, and it is pretty much subconscious or autonomic. You don't really have to think about it. When you're sleeping at night, it's not like you're, laying there sleeping and you're going and breathe out and breathe in and breathe out, right? Like you're not doing that because your autonomic nervous system does it for you, communicating to skeletal muscle, diaphragm, and intercostals. Okay, then you have your accessory breathing muscles. Okay, you might also read them as secondary. So shorthand is 2 degrees or secondary. So secondary breathing muscles. Okay, so accessory breathing muscles or secondary breathing muscles. Now, these are going to be muscles you're going to recruit on purpose, either because you're having a hard time breathing, okay, like COPD people, you're having a hard time breathing, or you're doing it on purpose, like blowing out birthday candles, breathing techniques like yoga and all these other techniques, they have breathing techniques, exercising, okay? And that's pretty much all the other muscles that have a rib connection, okay? Now, some of those main ones are going to be the sternocleidomastoid, the SCM, your scalenes, pectoralis minor, and these are the main ones, okay? And I'll explain what I mean by the main ones. Pectoralis minor, okay? Now, these three in particular, these will give people fits clinically and create problems, okay? So here's kind of the quick version, because we could talk forever about respiratory dysfunction, accessory breathing muscles, and all that. Okay, here's the quick version. The rib cage, your rib cage has to expand, okay, in order to breathe. Expand, and then, so increase in volume and decrease in volume. Increase in volume, decrease in volume. And you can do that through the normal breathing muscles, the primary breathing muscles, the diaphragm and the intercostals. And that's not going to wear you out. But some of these people with emphysema and COPD and other breathing problems, respiratory problems, the intercostals and the diaphragm is not enough anymore. So they have to recruit the sternocleidomastoids, scalenes, and pectoralis minor. Okay. Because if you look at the muscle attachment, all right, I'm going to try to draw some arrows here. Okay, if you look at the muscle attachment and the way the fibers are oriented on the rib cage, it will pull the muscles, pull the rib cage up and out. So you fire the SCM, the scalenes, pectoralis minor, okay? You're gonna help elevate the rib cage. That's an accessory breathing muscle or a secondary breathing muscle. They're not designed for that, but you can use them. And these people do, and they get worn out. And then they start to get neck problems, like musculoskeletal neck problems. And then their chest starts to hurt. And then they'll recruit the abdominal muscles, right? Because like the external obliques, the transverse abdominis and all that, because they have a rib attachment. Okay. So you start to recruit other accessory muscles, you get even more worn out. All right. Now keep in mind, during exercise and other controlled things, this is fine. But once people start getting into certain chronic respiratory conditions, this does absolutely wear them out. Okay. And then it starts to create some other musculoskeletal problems. So I see this quite a bit, actually. Now, can't really fix their COPD or emphysema or asthma, because that's not really what I do. That's more medical management, but I can definitely help them with the musculoskeletal part. And since I have them and they have all these respiratory issues, then I do try to visit with them on changing lifestyle habits, because it will take their situation and make it a little bit better. Okay. So we may not be able to cure it, but we can at least make it better, right? Okay. So the during inspiration, all right, so the ribs are elevated and the diaphragm moves inferior. So the ribs do elevates and the diaphragm moves inferior. Okay. So if this is your lungs, and there's the diaphragm at rest, the diaphragm will move inferior during contraction. Okay, so it's a little weird to think about, but a diaphragm contraction, it actually moves inferior. And by doing that, you're increasing the volume of the lung space. Okay, and then the diaphragm goes back to its rest position, which means it moves superior during its rest interval. Okay, so one more time, the diaphragm moves inferior during contraction and then moves superior during its relaxation time. Okay. Okay, the external intercostals help with inhale. The external intercostals help with inhale, and the internal help with exhale. Okay, external, inhale, internal, exhale. So what happens is the externals, they actually grab the rib below and pull it up. The external intercostals reach down, grab the rib below, and pull it up. So there's your up and out, or breathing in, or inhale. Okay. Now this one is saying it funny. It's saying the external intercostals relax. Okay, that's true. Okay, but also the internals are helping you, helping the ribs depress, go back down. Okay. So as you can see, I'm going to toggle back and forth. Look at the size of this rib cage compared to that one. Breathe in, breathe out. Inhale, increase volume. Exhale, decrease volume. Okay, the elasticity of the lungs help with that recoil. Okay, in patho, we'll learn when we get to respiratory dysfunction, you'll learn more about how that is important to be able to maintain your lung elasticity. But for right now, under normal circumstances, you do have elastic connective tissue that is woven throughout the lung field. It's called the stroma. Okay, the stroma of the lungs is kind of another way of saying the framework of the lungs, and it is largely elastic connective tissue to help it with that recoil. Okay, this is also known as the bucket handle effect. Okay, so as the ribs are moving up and out, the bucket handle also moves up and out. Okay, so that is a thing, it's a term. It's called the bucket handle effect. And likewise, when you take the bucket handle and you want to move it down, same thing, just the way that bucket handle would move down, the ribs behave the same way. Okay, so three things or three factors influence how easily air can move in and out and how much energy is needed. Okay, how much energy you need for ventilation. Airway resistance. So the bigger the opening, the better. the smaller the opening, the more difficult. Okay. Nice open tubes, the resistance is down. If the tubes are really skinny, small tubes, the resistance goes up. Okay, so that's why asthmatics, as the tube starts to constrict, or the tubes start to constrict, it is harder for them to breathe, therefore the resistance goes up. Okay, alveolar surface tension. Okay, a lot of that has to do with the surfactant. And then lung compliance. A big component of that is how elastic and recoil those lungs can do for you. Okay, also how much they can expand and how much air or oxygen can you get in. So the compliance, the volume. All right, so this one is showing the resistance in the different respiratory passageways. Okay, remember when you have a big open tube, there's not that much resistance. If you have a smaller tube, you're going to get more resistance. Okay, and the trachea starts out big and open. All right, and then once it splits into the primary bronchi, and I'm going to make this animation drawing very, like, I'm oversimplify it, but you can see that there's a big diameter here and then a smaller diameter there. And the more you work your way toward the terminal ends, the tubes they taper smaller and smaller. Okay. So by the end of where the alveoli and the bronchi and all that, where they are, the diameter is much smaller than when you first started out in the trachea. Okay, so the resistance in the big tubes, not that much. Okay, as you can see here, and then the resistance once you get to the terminal bronchioles is more. Now, all this is within normal, right? I mean, tubes just start out big in diameter and they taper to smaller, and so the resistance changes as you get toward the terminal ends, and that's okay. All right, so the values start to come into play when you are assessing someone that you're suspicious of some sort of respiratory disorder like asthma or, chronic bronchitis or something like that. Okay, epinephrine helps dilate the bronchioles by binding to the B2 receptors. Okay, so even in skeletal muscle, the alpha receptors will vasoconstrict, the beta receptors vasodilate. Okay, so the B2 receptors in the bronchioles, when acted upon by epinephrine, will dilate. Okay, the surfactant, which is a combination of lipids and proteins produced by those type 2 alveolar cells. Okay, they help reduce the surface tension of the alveolar fluid. Okay, it also will prevent the alveolar, remember, kind of like a grape, you kind of visualize them like a grape, prevents them from collapsing. Okay, if these are insufficient. It does cause breathing problems, and in infants, it can cause respiratory distress syndrome in the infants. And that's because the alveoli collapse after each breath, and you don't want that. You want them to stay nice and open. Okay, so respiratory distress usually means the alveoli are collapsing after each breath. Okay, so this graph is trying to show you where when it's nice and big and open, the pressure, so you can see the P there, the pressure is less, okay? And when the diameter gets smaller, the pressure will go up. Okay, and this has to do with part of Laplace's law, okay, about the nice open diameter, the pressure goes down, a smaller diameter, the pressure goes up. And then where surfactant comes into play is it helps reduce the surface tension. So pressure is equalized. Okay, so even though this diameter is bigger, okay, the spacing out will still keep the pressure at around 2. And if the diameter gets smaller, the surfactant gets more condensed, but it still keeps it as a pressure of 2. Because the surfactant knows how to equalize itself. Okay, lung compliance, okay, we mentioned this earlier, basically has to do with the ease of the expansion of the lungs. Okay, one thing that can happen for a variety of reasons, either lung injury, and pretty much the main way people injure their lungs in our culture is smoking. Okay, and there can be other things. It could be where you work, you know, hazardous material, chemicals, stuff you're breathing in. Are you a coal miner, a sandblaster, whatever, right? All these different professions that give you risk for lung issues are things to consider as well. And another one is aging. Okay, so ways we can hurt our own lung tissue on purpose, such as smoking. Okay, other things that can hurt lung tissue, such as chronic reoccurring infections, like tuberculosis. And then another one that can hurt lung tissue would be just a natural course of aging. Okay, but lung compliance can be decreased because of those. And you're seeing here a picture of the decreased flexibility that the lung would have because the elastic tissue is being replaced by scar tissue. Okay, that would be fibrosis of the lung. So kind of a fancy way of saying fibrotic tissue. So in lay terms, it's scar tissue. In fancy terms, it would be fibrotic tissue. Okay, with respiratory volume, this tidal volume is a way of saying like normal. This is the normal amount of gases or air that you want, you know, the volume of that inside of a person. So that's your tidal volume, okay? Then you have this inspiratory reserve volume, or IRV, okay? And this is the additional amount of air that can be inhaled after normal inhale, okay? Because it's a reserve. Okay, I'll say that again. The IRV, or inspiratory reserve volume, is the additional amount of air that can be inhaled after normal inhalation. Okay, so right now everyone is pretty much breathing normal. You inhale, and then at some point you exhale. Okay, but what you could do is inhale like normal, and then instead of exhaling, just keep inhaling. At this point, make yourself inhale. Okay, that's getting into your reserve volume. All right. So then your expiratory reserve volume, okay, or ERV, expiratory reserve volume, is the reserve amount that can be exhaled beyond your normal exhale. Okay, so in other words, you're breathing out, exhaling, and at some point you just breathe in again. Okay, but this time, instead of, once you breathe out and right before you're going to breathe in, just keep breathing out. Exhale all your air. Get rid of as much as you can. Okay, that's your reserve, your exhale reserve. Okay, now some people, when they're doing hypoxic training, like swimmers, for example, synchronized swimmers, okay, and like even some military special forces that do underwater tactical stuff, like your Navy SEALs, okay, they do a lot of this kind of training. Okay, I'm not going to get into all those details because we could talk about it for forever. But basically, it's a type of hypoxic training, teaching your body how to be underwater for longer periods of time. Okay, 3 minutes underwater, 5 minutes underwater, 6 minutes underwater. And they tap into this. Okay, the inspiratory reserve volume, tidal volume, expiratory, all that. Okay, it's part of the training for holding your breath underwater. Okay, anyway, one of the things they'll do is exhale as far as they can, get everything out, get rid of the expiratory reserve volume, and then you go underwater to hold your breath, see how long you can do it. Okay, that's one example of hypoxic training. Okay, the residual volume is the amount of air that's left after your reserve volume is exhaled. Okay, that's the residual, or known as RV. The amount of air that's left after the expiratory reserve volume is exhaled. All right. So when you're testing people on a spirometer, okay, so when you're testing people on a spirometer, you're going to pinch off their nose, put a tube in their mouth, have them breathe normal, measure all the stuff, okay, inhale, exhale, then have them inhale as far as they can, see what kind of number you get, and then have them exhale as far as you can, see what kind of number you get. Then you can start doing your math, okay, to get total lung capacity. Okay. So if you're a humpback whale, it's probably 60 million milliliters per, I made that up. I don't know. Their lungs are just so big in a humpback whale, right? Then you have humans, and then you have like super athletes like Lance Armstrong, and just anybody else that's an endurance athlete where their total lung capacity would be very impressive. And then you have size, just the size of the person, because their lung field is so big, like Shaquille O'Neal. I wonder what his is. Gosh, that guy, I think he's what, 7'1", 7'1", and 300 some pounds. I mean, that is a big chest cavity, right? So I wonder what his is. Anyway, this is normal. So what you're looking at here would be considered normal. Men actually are usually on average around 500 milliliters per kilogram, and women on average are about 400 milliliters per kilogram. Okay, some more definitions here. Internal respiration is the diffuse of gases in the lungs. Okay, so external respiration, the diffuses of gas in the lungs. Internal respiration is diffusion of gases at the tissue level. Okay. So you start to run, your quad muscles are starting to increase in their oxygen supply and demand. So your body is delivering massive amounts of oxygen to the quads in this running example. That would be internal respiration, the diffuse of gas at the body tissue. And in that easy example with running, the quads are going to be enduring a lot more of oxygen supply and demand stuff than, say, your bicep brachii of the arm. Okay, Dalton's law, right? Likely another thing you'll see on boards. Okay, it has to do with partial pressure. So Dalton's law, the total pressure exerted by the mixture of gases equals the sum of the pressure exerted by each gas. Okay, now I'm not going to have you do any calculations. I just wanted to put that on because you'll likely see it on board. The formula is quite fancy. Okay, on this one, I'm not going to worry about that one. All right. Okay, on this, the partial pressure gradient that promotes gas movement in the body, okay, we do need pressure to move things through the body. Okay, we do need things, so pressure to move things through the body. Okay, so part of that is going to be the heart. All right, so the pressure of the heart. Okay, so as blood is leaving the lungs and entering to tissue capillaries, you're going to get a partial pressure of oxygen of about 100 millimeters of mercury. Okay, and of the CO2 part, about 40 millimeters of mercury. In other words, the amount of oxygen found in the arterial system is going to be pretty high. The amount of oxygen in your arterial system is going to be pretty high, about 100 millimeters of mercury of your PO2, partial pressure in the artery system. Once you get into your vein system, okay, once you get into the vein system, you're going to find more CO2, okay, about 45 millimeters of mercury of pressure of your PCO2, and about 40 millimeters of mercury of your oxygen. So in other words, less oxygen in your vein system. Okay, so oxygen transportation is bound to hemoglobin. Okay, so one red blood cell does have, okay, let me say that better. One red blood cell has a lot of hemoglobin on it, and one hemoglobin can bind, I should do this in red. Okay, so one hemoglobin can bind 4 oxygen molecules to it. Okay, the 4, so here's your oxygen, right? So there's your binding sites. Okay, so they are loosely bound. Iron, or Fe, is, so you have iron and the heme part and the protein part, the globulin. So together we get the hemoglobin. And you get 4 oxygen per hemoglobin. So that's what I tried to draw there. And there's lots and lots of hemoglobin on one red blood cell. Okay. And then eventually what happens is the oxygen is delivered to the tissue. Okay. And then the PCO2 is picked up. And that's what enters into your vein system to eventually for you to breathe that out. Okay, don't worry about this one. Okay, as CO2 is trying to eventually exit your body, okay, it is bound, about 20% of it is bound to the carb amino hemoglobin. Okay, some of it is also dissolved in the plasma, and about 70% is transported as a bicarbonate ion. Okay, so breathing, hold on a sec. Yeah, so we're going to get to the nerve stuff in a minute. So breathing and its effect on the respiratory system has to do with your chemoreceptors. Okay. So if there's a chemical change in your body, so in other words, you start to get an increase in CO2. Okay. That means you're dropping in pH, meaning becoming more acidic. Okay. Then your body will compensate by starting to breathe more rapidly. So if you increase in CO2, your body's like, uh-oh, if we keep going in this route, we're going to become more acidic. No problem. I'll just increase the rate of my breathing to get rid of more CO2. And as a result, more oxygen will come in. Okay, the perfusion is the amount of blood flow reaching the alveoli, okay, through those pulmonary capillaries. So how much blood are we actually getting to the alveoli? And then the ventilation part is the amount of gas reaching the alveoli, right? Because as all this stuff is coming in, you can kind of look at it. You've got fluid coming in, which is the blood part, and then you have gases coming in, which is your oxygen and CO2 part. So perfusion would be the blood flow part, and ventilation would be the gas part. Okay, I mentioned this before. I guess at this point, it's a reminder. Sympathetics will create bronchial dilation, and parasympathetics would create bronchial constriction. Okay, so when you get stressed, and there's, I've talked about two forms of stress. Okay, two forms of stress: controlled and, just to keep it simple, non-controlled. Okay, controlled stress would be like exercise. So you're doing it on purpose, and this is a healthy form of stress. Non-controlled would be like the so-called life stress, like the anxiety you would feel from the test, a test, or, you know, the riots and this zombie apocalypse 2020 and whatever, right? Traffic, you know, all these stressors that are at risk for stressing you out. And there's other things, you know, you have to also mix that with, you know, just some people are just angry and they're bitter and they're hurt and they're wounded. And over the years, and all this compounds and adds up, and they're just one walking pissed off ball of stress. Okay. And that's the one that's going to hurt you in the long run. Okay. because stress suppresses your immune system. It decreases digestive function. You can risk adrenal burnout and the cortisol release and changes in blood sugar metabolism, and on it goes. Okay. So that kind of stress is not good for you in the long run. Okay. However, during sympathetic stimulation, you get bronchial dilation, and parasympathetics, you get bronchial constriction. All right. Neurologically, okay, the pons and the medulla are going to help you breathe. Okay. So the diaphragm, so we have C3, C4, and C5. So cervical nerve roots, C3 through 5. Okay, so there's an expression that goes C3, C4, C5 keeps the diaphragm alive. Okay, C3, C4, C5 keeps the diaphragm alive. And C3, C4, C5, when you put those nerves together, it's the phrenic nerve. Okay, C3, C4, C5 keeps the diaphragm alive. And they branch off of the spinal cord. Okay, so let's go back to ANP1, the nervous system, right? There's the spinal cord, and the spinal cord, which ultimately is connected to the brain. So brain stem, spinal cord. Then you've got the nerve roots that come off of the spinal cord, and then those, just like a tree, they branch, and they branch again, and then they branch a million times, right? Just like a tree. Well, that nerve root, so C3, C4, C5, eventually those branches connect together and make the phrenic nerve, and that goes down to the diaphragm. So that's where the expression C3, C4, C5 keeps the diaphragm alive comes from, just to kind of make it easy and fun to try to remember. Okay, another way is from cranial nerve 10, okay, so the vagus nerve. Okay, so the cranial nerve 10 comes out and innervates the chemoreceptors, right? So the aortic arch and the carotids. Okay. So the chemoreceptors are going to pick up on a change in your gases, so a chemical change. And then we'll send a signal back to the brain, or more specifically the brain stem, to change the rate at which you're going to breathe. So if it picks up on the chemical change of more CO2, then the nerve signal ticks faster, so you breathe faster. As an example there. Okay, this would be a picture of a healthy lung, or a non-smoker's lung. And here is a picture of a smoker's lung. Okay. So, I mean, it's really no secret that smoking hurts everything, especially the respiratory system. I have never met a smoker that doesn't know that what they're doing is hurting themselves. Okay, I mean, ever have that conversation? Hey, did you know smoking is bad for you? And the smoker goes, yeah, I've never heard that before. I mean, they know. Okay. But it's a habit, it's a lifestyle choice. And as we all know, it's very difficult for anybody to change our lifestyle choices. Doable, but very difficult. Okay. But even in the face of that, still try to encourage those that you can influence, friends, family, patients, to stop smoking, okay? Because it does cause problems in the long run. So cancer would be one of them. Emphysema, which by the way, those are called pink puffers because they have a hard time exhaling. Okay, so they have to force the air out, and that constant work of trying to force the air out kind of turns them flush colored. So they're known as pink puffers. In COPD, those are known as blue bloaters. Okay, because they have that cyanotic look because they're not getting enough oxygen. So they kind of look pale, bluish. Now there's different degrees of that. It can be very subtle or severe, like blue around the lips, blue around the fingernails. Okay, that overall kind of pale and or cyanotic look. All right, any questions or anything over this? Okay, I am going to, so here in a minute, we're gonna break for, actually, hold on.